Hi, everyone. I'm Mark Pletcher. I'm the Chair of Epidemiology and Biostatistics at UCSF. Also direct the informatics program for our Clinical and Translational Sciences Institute. I'm happy to moderate session number 4, which is Outside the Clinic, Wearables, Open Platforms, and Research. Our first speaker today will be my colleague, Ida Sim, who is a professor of medicine at UCSF, co-director at the UCSF, UC Berkeley Joint Program in Computational Precision Health. UCSF served as UCSF's first chief research informatics officer and is a practicing primary care physician. Welcome, Ida.
Thank you. And we'll move on. All right. I think before AI was the buzzword, there were other buzzwords in our field, right? And I think precision medicine was one of those buzzwords. I think we hear about it a little less now that AI has taken over. But I do want to dive a little bit into the term precision, because that's really what we want, right? You've heard a lot today about going beyond population level or, all of EHR and predicting how all doctors should treat all patients. It's about doing the right thing, the right person at the right time. And often when we think about precision medicine, I think maybe in those sort of older days, there was a lot of, it's omics, right? It's DNA, geno, pheno, mostly just geno. And now we think about sort of biological complexity. And those of you in biomedical research, of course, there's AI and models, foundation models at every single level of biological complexity. This is one view of precision medicine, obviously very important. I think of this as below the skin discovery in precision medicine. Complementary to that is above the skin, where the human is not an organism. The human is a person. It's a person who has a life, who lives in the community, gets help from a very problematic healthcare system, and then on up through public and community health. And CPH is more in the above the skin, but we also have work in below the skin, as you've heard from some of our presenters today. So I want to dive down into more of a framing of what precision medicine means for sort of above the skin. I think you've heard from a lot of people today that, the problem in healthcare, just sort of broadly speaking, that our healthcare systems operate in silos, right? We don't have real-time data access as much as we would like for either clinicians or patients. Very inefficient workflows, lots of waste, lots of innovations you see in this room, on this campus and on the other campus that don't come out to the clinic. I see my patients now and I treat them the way I treated them, not that differently than when I started practicing. Integration challenges are huge. I think we heard that in the first session, right? Tremendous number of problems. What are the opportunities? Rise of AI models, as you heard, foundation models. This session, we're talking more about wearables and about reaching out beyond the healthcare system, beyond the walls and of the hospital and the clinic. Real-time data integration. I'm a primary care doc, so you would think that I take care of chronic diseases. I do not. My patients take care of their chronic diseases, without question. They're the ones who are their caregivers. And we do almost nothing to support them. And I see Hugo nodding his head. Maybe we'll be hearing from Hugo from the patient perspective, but we're all patients, right? If not now, maybe later. So let's talk about precision care for individuals. Patient-generated data that are a remote window into our health state 24/7. Two major types. One is patient-reported outcomes. It should be, are you fatigued? Are you confused? Are you sad? Medical sensors, blood pressure cuffs, glucometers, we've heard a bit about that. Aura, Apple Watch, a whole bunch of sensors, many more that will be invented in the next few years. But really what we have right now, 1,000 flowers blooming, right, just down the peninsula in Silicon Valley, and a huge case of allergies for some of you. And yet what we want a bouquet of flowers that are put together beautiful, not the mess of flowers or weeds, as they mean. But really, we don't want to have just one bouquet. I mean, we think about that and we go, oh, we need a bouquet for primary care. Or we need a bouquet for GI clinic. No, we actually need bouquets for each and every one of us, because each and every one of us need different data for our own conditions. And not only that, but we need different bouquets for each of us at different times. As we get sicker, as we get better, as we get discharged from the hospital, we need individualized bouquets that mix and match over time. That's the precision care our patients want. That's the precision care our patients deserve. And yet it's impossibly difficult to do that. What we do not have, what we need is to get to these precision bouquets is an ecosystem of modular standards-based composable solutions. And I got that from, colleague Deborah Estrin from way back, who comes from the internet world. And, there should just be modular interfaces, the standardized APIs. But that's that notion of building modular composable solutions that allow us to mix and match and meet us where we are. What we need is what we're calling Jupiter Health. I am seeing Fernando Perez way in the back there, my co-conspirator. He is the founder of Jupiter. Many of you have probably heard about it. It's 10 computer codes that transformed science and really has transformed science. And in fact, it's had wide industrial adoption across many science domains. You see the companies here; they're all in the big clouds, and many companies build Jupiter on the back end. So what we're proposing is to take Jupiter. What we are doing actually is to take Jupiter, bring it to healthcare. The 20% of GDP that is healthcare, going from the 1,000 flowers blooming to an ecosystem by which we can compose these bouquets. So I'm going to talk us through the bottom of this. So think of the Jupiter Health ecosystem that we're building as being both the horizontal, which is the infrastructure platform itself, and then vertical solutions that I'll get to in a little bit. But just to start off, data ingestion is actually a huge thing. How do patients bring in their sensor data in a way that doesn't involve 3 apps, 6 passwords, and getting into MyChart, because that's a non-starter, okay? So we have Common Health working with Google and Apple to bring sensor data in. We can bring in US CDI data, for those of you who know, using HL7 FHIR standards. We need to standardize and transform. We've talked a lot about that. We're based on FHIR standards, HL7 FHIR, and OpenM Health, IEEE standards, which is part of my work from years and years ago. A FHIR authentication. Of course, this needs to be a privacy preserving platform. This is where the Jupiter partnership makes a lot of sense. Management and analysis, all those AI tools, Jupiter AI, all the analytic tools, all the machine learning tools, and the visualization tools, voila, and so forth. All of this Jupiter Health can borrow from the Jupiter ecosystem, the Jupiter economy, and of course the Jupiter commercial world as well. We talked about deployment. So the other vision we have of Jupiter Health is this is for developing solutions, but getting solutions into the EHR, into Epic is really, really hard. So what we want in this Jupiter Health is to package solutions in such a way that they can be easily plopped into ops, into operations, using a Smart on FHIR wrapper. So there are standards now that are national standards. So really taking this as a DevOps platform, we're doing this at UCSF Health. We focus on hypertension, diabetes, respiratory health. At Cornell, this is climate and sleep with the Oura Ring. That's heart failure. Columbia is focused on patient engagement, because a lot of this is sort of how we help our patients. And then you've heard from John and from Maya. NIT Health is the large clinical model that you've heard them talk about, and how that kind of a brain, we think of like Jupiter Health as a body and the large clinical behavioral model is sort of the brain. And like putting that together really gets us that power foundation to build our ecosystem. I think we need this because right now, digital health is billions and billions of dollars invested, always in just vertical silos where everybody builds things over and over again. And then they go sell to Epic or to UCSF or to Geisinger. And, it just collapses. There's no bandwidth. There's no staffing. There's no money to integrate into a health system and then maintain each and every integration. So we're really trying to streamline that. So what sets Jupiter Health apart? You've heard large platforms that are out in the world. What sets Jupiter Health apart, it is interoperable across ecosystems. Open source, I think we really do want to lean into open source. It's how we go further, faster together. It supports both research and care. Obviously, me as a clinician and as a researcher and training students here, research and care are two sides of the same coin, and we need to build infrastructures for both. The composability, I think, is incredibly important. 2/3 of Americans have more than one chronic disease. We cannot build a solution for diabetes and a solution for heart failure and a solution for hypertension. It needs to be composable. Transparency and reproducibility, of course. And we have a very transdisciplinary team across Berkeley, across UCSF, across Duke, and many others as well. It really is a exemplary of the kind of community that we can build between UCSF and Berkeley. So do talk to us as you see us here, and thank you.
All right, thanks, Ida. Our next speaker will be Asandhya Subramanian. She is a assistant professor at the UCSF UC Berkeley Joint Program in CPH. Come on up, Asandhya.
So thank you. I'm going to talk about what I'm really interested in and what I work on, which is monitoring and modeling the body outside of the clinic. So the question that really interests me is, why is information transfer in healthcare so dependent on a doctor-patient exchange? So what I mean by that is all of us spend a very small fraction of our time in a clinical setting, typically. We spend the majority of our time living the rest of our lives, which includes a lot of behaviors and choices that affect our health. For example, what we eat, or how, our eating habits, our sleeping habits, physical activity, social interactions, any symptoms or signs that we experience outside of being in a clinical setting. However, all of these are currently not in the purview of the healthcare system unless we choose to bring it up to a clinician when we go in for an appointment. So what that means is there's a vast ocean of information that could be valuable and probably is very valuable to understanding our health state that's currently not in the purview of the healthcare system. So that's the majority of everything that happens outside of the clinic, because there's only so much you can tell your doctor in a 20-minute appointment. There are a lot of situations in which patients cannot act as reliable advocates for themselves. That could be because of a health state that they have or health condition that they have. That could be because they live alone and they perhaps don't have other people around them that are observing things about them that could be informative to their clinician. There could be because of cultural barriers, language barriers. There's a variety of reasons why a patient cannot act as the most reliable information bearer for themselves. And then there's an entire layer of information that even the most well-informed, observant patient could not communicate about their own health because it's below the level of their conscious perception. So what I'm interested in is figuring out, how do we bring this entire ocean of information, or at least some of it, into the purview of the healthcare system so that it can be incorporated into the decisions that are made about a person's health. So I spend a lot of time thinking about something called the autonomic nervous system, which is basically the branch of the nervous system that is responsible for everything that keeps the lights on, so to speak, in our body, but we don't spend any conscious effort or energy thinking about. So that includes keeping our heart beating, keeping us breathing, digestion, bladder function, kidney function, sweating, hormones. None of this you spend any conscious energy thinking about. It's always working 24/7. Even if you are unconscious, the autonomic nervous system still has to function. And by definition, it is below the level of your conscious perception. So you cannot go and report to your doctor how you think your stomach muscular function is doing. And what's interesting about this in terms of how the healthcare system currently treats this is, if you think about it, every one of these organs has a different specialty, a different medical specialty that's responsible for it and treats it. And so we don't really often think of it as a holistic picture, when in fact a lot of complex chronic diseases manifest as this weird complex syndrome of symptoms that kind of shows up across the entire body. So what are the opportunities for exploration that I'm really interested in? As an engineer, I'm really interested in how do we engineer wearable sensor systems for the real world. And that's part of what I work on, is building, prototyping different wearable sensor tools to allow us to collect clinical grade data in not clinical settings. And you know, all of us who work in computational spaces understand that the computational part of it can only do as well as the quality and the richness of the actual data that we have. So the hardware also makes a big difference. As a applied mathematician and statistician, I'm really interested in what are the new machine learning and AI models we need to build to understand signals from the body. And specifically, how do we equip them, or how do we empower them with the many decades and century of physiologic knowledge that we have accumulated about how these physiological signals are actually generated. And then as a physiologist and neuroscientist, I'm really interested in where there are untapped opportunities in clinical medicine to better understand individual physiology. So I work across a wide array of disease spaces, because the autonomic nervous system actually touches basically every organ system in the body. There's, I think, a lot of untapped potential for wearable monitoring that is currently still underexplored. Scientifically, it gives us a really interesting window into understanding individual variability and complexity in physiology. It also gives us the opportunity to track personalized treatment strategies on a person-by-person basis. So as an example, this is work that I did previously, where we built individual models to estimate unconscious pain processing when people are in surgery and they're under anesthesia. So the current standard for measuring pain in a clinical setting is to ask someone how they feel on a scale from 0 to 10. Obviously, that is not an option when they are having surgery. So what we did is we used wearable sensors to tap into their fight or flight reflex, which is, believe it or not, intact when you are unconscious, and to use that to be able to estimate when their body is actually still processing unconscious pain, with the end goal of using this to be able to inform anesthetic dosing. And this work was published last fall in PNAS. In terms of scalability, wearable monitoring is, we've barely scraped the surface. Everything that I work on right now is non-invasive, which means that you can use it 24/7. You can use it in at-home settings. You can use it while people, you don't have to make people live in house arrest. You can have them go out and be able to live their life. This is just a smattering of the different kind of wearable systems that we prototype, build, and work with in the lab. And of course, the end goal for all of this in terms of impact is to be able to provide richer insight to the clinician and to maximize patient quality of life. So for example, this is previous work that I did where we did 24/7 at-home monitoring for just one 24-hour snapshot for healthy controls in patients who have something called gastroparesis, which is a functional digestive disorder where food sits around in the stomach for longer than it should and doesn't move to the small intestine. And we don't quite know why, but there are a couple different kind of categories of hypotheses we have about what could be contributing to it. But it's a diagnosis of exclusion. So basically, you define it based on a cluster of symptoms and you rule out everything else that you think it could have been, and then you end up with that diagnosis. And so what we did is we had people wear not just sensors that monitored their stomach activity, but we also, in order to get a kind of multimodal autonomic picture, also had them wear sensors that were monitoring their heart activity, which in theory might seem unrelated. But actually, what I'm showing you here, so actually I'm not going to tell you what the axes represent. If you already know what those words mean, don't tell anyone near you. But if you just, without knowing anything about what the axes are, if you just looked at the healthy control and the patient, and you just saw roughly wake and sleep, there's a big difference. The healthy person, there's a big difference between wake and sleep, and that's normal. Your autonomic regulation, it's almost two very distinct states between wake and sleep. Circadian rhythm is a big deal. Versus in the patient, there's almost no change the entire time. And what this actually is these are all metrics that are derived from their heart activity, not their stomach activity. So this is showing the circadian regulation of their heart and not actually directly their stomach activity. And you can see that the autonomic nervous system has this really interesting role of turning what seems like a local problem into a more global dysfunction, which helps contribute to a lot of these diseases' kind of syndromic presentation. This is another part of that study where we happen to actually be able to track a single person at various stages of their recovery. So this person had an obstruction specifically between their stomach and their small intestine, and they had surgery to fix it. So what we did is we got one 24-hour snapshot before they had surgery, one pretty shortly after they had surgery, and then one a year later. And once again, what I'm showing here is actually kind of the regulatory metrics that are computed from the regulatory activity of the heart. And what we saw is that before surgery, it looked very abnormal. And then by a year after surgery, it basically returned to looking like that of a healthy person. So not only was this also showing the idea that the autonomic can translate the local to the global and the global to the local, but also that we could track for an individual person their trajectory over time by just taking these snapshots using at-home monitoring. And then what we also did is we defined kind of prototypes of scores that were able to distinguish between subtypes of gastroparesis in terms of the intensity of the autonomic activity as well as the appropriateness of the regulation. A lot of the work that I do is developing what I think of or what I call physiology-informed AI tools to be able to understand the data that we collect. And what I mean by that is to kind of marry the power of the models, the computational power, with the many years of physiology that we have. And so how do we make the model smarter by understanding physiologic principles? And in terms of impact, I think of impact as being on a continuum. So there are application spaces or disease areas in which we really don't even understand the disease well enough yet. So there's a lot of potential and scope to just understand better individual physiology in the disease. Then, you move into having enough information to start thinking about clinical decision support tools. But eventually, I think the holy grail in every situation is to work towards personalized prediction and closed loop control. And then I will end by thanking my lab and collaborators, and I listed a smattering of the work that we have ongoing in the lab. Thank you.
Okay, speaker number 3 is Serena Chang. She will join UC Berkeley as an assistant professor this summer with a joint appointment in Computational Precision Health Program and UC Berkeley's EECS department. Welcome, Serena.
All right, thanks so much for that introduction. So today I'm going to be talking about inferring population health and behaviors from novel data sources. So to begin, public health relies deeply on population behaviors. For example, we care a lot about contact networks, which define patterns of contact between individuals over which things like infectious diseases spread. So these contact networks and their structure mediate the spread of these diseases, which is why we care deeply about them, as well as to understand how to control the spread of these diseases. Another behavior of a lot of importance is vaccines. So understanding who is taking vaccines, who is not taking them, and then various reasons for vaccine hesitancy. There are lots of other behaviors that matter, like exercise or diet, as well as more subtle features like social networks and the kinds of information that you ingest and how that influences your values and your beliefs, and then ultimately the health behaviors that you make. The challenge is that the vast majority of these behaviors happen outside of the clinic. They happen outside of the hospital. And so because they are so difficult to observe, what can we do about that? So in my work, what I'm doing is we're really trying to leverage novel data sources in order to estimate these behaviors so that we can make better public health decisions. So this includes novel data sources such as social media or search logs or geolocation data that comes from your cell phones. So these are large-scale, passively collected data sources constantly firing, capturing billions of people. And what's really nice about this data is that because it's at such a scale, you can actually infer heterogeneous behaviors across subpopulations, and you can also capture dynamics over time in real time as those behaviors change. And then I take these behaviors that we've estimated to try to make more tailored and precise public health policies, for example, policies that are specific to the needs of each community, as well as policies that can adapt over time as these behaviors change over time. But I've left out a big part here, which is the hard part. how do we take these vast, massive, messy data sources and distill them into signals that can then guide public health decisions? There's a lot of challenges here. For example, how do you get precise signals, leaving out all the other parts of the data that you don't need? How do you do this in a way that scales? How do you then validate the inferences that you make? Because we're in a regime where the ground truth is so hard to observe, how do you know if your inferences are correct at all? And of course, how do you balance needs of privacy for various people and their data with the utility that you get out of that data? And how do you address issues like missingness and bias, for example, for people who don't show up in the data at all? So this is where AI and machine learning comes in for me, which is addressing these various challenges so we can actually distill these massive, messy data sources into precise signals. So today I'm going to give you two vignettes, two examples of how we can use various novel data sources to learn something about behavior. The first one is about mobility data and contact networks. So like I mentioned earlier, these contact networks are really crucial for both modeling the spread of disease as well as mitigating it. But the challenge is that usually we don't know the true contact network. So in our past work, our solution has been to actually infer a fine-grained contact network directly from aggregated location data. And this was real data from people's cell phones during the COVID pandemic, so we could actually understand who was coming into contact with whom during the pandemic. Specifically, the network that we wanted to infer is this bipartite network, where we wanted to know in every single hour how many people from each census block group, so these are neighborhoods of around 300 to 6,000 people, how many people from each census block group visited each point of interest. These are individual public locations, such as restaurants, grocery stores, and so on. And we want to infer this so we can model spread based on who was visiting where at the same time. The issue is that in the location data that we had, we didn't actually have this hourly CBG to POI network. What we had, first of all, were the totals. So we knew in every single hour how many visitors there were in total to each POI and how many visitors coming out of each CBG in every hour. That gives you the hourly information, but no network. Conveniently, we also had monthly estimates for each point of interest of which census block groups the visitors were coming from. And so the core question, the technical challenge here, is how do we reconcile these pieces of information to infer these hourly networks? I won't get into the mathematical specifics here, but we found that we could actually repurpose this classic statistical algorithm called iterative proportional fitting, or IPF, that allows us to infer hourly networks that are consistent with the hourly totals, but otherwise as similar as possible to the distribution of the monthly network. Then what we did was we used this algorithm, IPF, to infer hourly networks for 10 of the largest metropolitan areas in the US. IPF is this really nice lightweight algorithm, which you can do in parallel. So we were able to infer these large scale networks with 5.4 billion hourly edges. And what was nice was because we packed so much complexity into these networks, the remaining epidemiological model could be very simple. So our model only has 3 free parameters, all fixed over time. Despite that simplicity, we are able to fit real COVID cases in all of the 10 metropolitan areas quite accurately. So there's a couple of things you can do with this really rich model now. First of all, we can explore various reopening policies, and in particular, look at competing objectives. So for decision makers, on one hand, they definitely want to minimize infections, right? So that's the y-axis here. But on the other hand, there are competing objectives of trying to reopen the economy and have business needs and consumer needs. So we could use mobility as a proxy for that. What we found is there are certainly trade-offs between the two, but with clever strategies, such as tailored reopening policies, you could actually get a lot of bang for your buck. So a small reduction in visits could give you a large reduction in infections. We are also able to study socioeconomic disparities with this model. So we could see, for example, that the model without any demographic information predicted from the mobility networks alone that there were socioeconomic disparities in COVID rates. And finally, when this work was released in Nature, we were excited to see broad impact and coverage. The work was cited by policymakers around the world. And we also deployed our model as a decision support tool for the Virginia Department of Health during the pandemic to help them assess in a data-driven way various reopening plans. So you can do a lot with this mobility data and contact networks. This is just a slice of the work that we've done in this area. I'm going to briefly tell you about a different data source now. This is search logs, and this is work that I did with our great keynote speaker, Eric Horvitz, along with Adam Forney at Microsoft Research. So the challenge here is that public health officials, they need vaccine data. They need to know who has gotten vaccinated and who hasn't for a number of reasons. For example, to estimate disease risks based on susceptibility, or to be able to figure out where should we place vaccine sites, or who should we reach for targeted vaccine campaigns. But the challenge is that existing vaccine rates, they tend to be delayed, missing below the county level, missing important demographics, and possibly suffering from self-reporting biases. So in our work, our key idea is that you can leverage large-scale anonymized search logs to help with this data gap. And the key insight is that you can actually very precisely see when someone is trying to get the COVID vaccine or any other vaccine, because they will query things like COVID vaccine near me or CVS COVID vaccine. So now you can pinpoint this thing that we call vaccine intent, which is someone trying to get the vaccine. Based on that, you can aggregate the signals upwards to get estimates of vaccine rates. And you can also better understand people's vaccine concerns by looking at their other search behavior around the moment when they're looking for a vaccine. So the key technical challenge here is how do we actually develop a vaccine intent classifier that can do this accurately? Again, I won't go into the details, but essentially we turn this into a graph machine learning problem that allows us to detect vaccine intent with a lot of accuracy. To quantify that a bit, we get manual annotations of vaccine intent, and we show that our classifier achieves AUCs and precision above 0.9 in all 50 states. And it also achieves strong correlations with vaccine rates reported by the CDC. So this is great validation, but there's also additional things that our search signals provide. So first of all, we can see that CDC reporting actually lags the search signals by 1 to 2 weeks. And that's the delay that it takes from showing vaccine intent to getting your vaccination, to having it reported by your local public health department, to having it compiled by the CDC, to having that reported in a way that researchers can use. The second thing is the CDC only releases this data up to the county level, and now we're able to do this at a much finer granularity at a zip code level, which is 10x the granularity of counties. I'm leaving out some of the other analysis from our work, including analyses of vaccine holdouts and their news consumption and various concerns. But in conclusion, I told you today about two data sources, search logs and mobility data, that contain a lot of promise for helping us understand population behaviors that happen outside of the hospital. And in ongoing work, we're interested in continuing this kind of work, exploring multimodality. So can we link these data sources to get even richer understandings of people, as well as can we bring in generative AI? So instead of only inferring these behaviors, can we actually simulate and generate these behaviors so that we can do this in a predictive and forecasting way instead of only retrospectively? So thanks so much for listening.
Okay. Get some time with our speakers here. Thanks for all the great talks. I think I have a couple questions that I wanted to just start with, and then the audience will open discussion to the audience. I think you all are using data from outside of the health system, healthcare delivery, to make real-time insights that hopefully are useful to somebody. And I think for each of you, we're not talking about sort of causal inference, creating generalizable knowledge in a general way. We're talking about a specific moment in time for an individual patient or for an individual health system or county where they're thinking about making policy decisions, et cetera. So that's a hard problem. And it's in some ways it's a design problem. You have to design the output of your systems, your wearables, your computational algorithms to be useful for a user. And so I wanted to just ask you all about that a bit. And maybe I'll start with Serena. You had I think a really nice and impressive demonstration of utility for, I think, a local government used one of your tools during the COVID pandemic. Yeah. So maybe you could just tell us about how that came about, how you implemented it in a way that was useful for the policymakers.
Yeah, this is a great question. And I am very passionate about actually translating these sort of tools that we make into actual deployments for decision makers. We had an ongoing relationship with the Virginia Department of Health during the pandemic. So we delivered a number of things to them. Among that, one of the problems they had was where to place vaccine sites. So they had a limited budget of vaccine sites. These are basically trucks that are carrying the Johnson & Johnson vaccine. So one shot and done. And the question is down to a level of which block should I be placing this vaccine site in order to maximize the usage of them. And so here we were able to leverage mobility data as a way to guide those recommendations under the theory of if you place a vaccine site near somewhere that people are already visiting a lot, then that maximizes convenience for them. In addition, we are able to target under-vaccinated communities. So certain communities that they were trying to reach through these campaigns, like Black and Latinx communities, we were able to actually take the aggregated mobility patterns of those communities to get those recommendations. And in this paper that we have, we show that which community you're trying to target matters quite a bit. So the recommendations, the top K, changes a lot based on which community you care about, which speaks to this sort of precision community health and community medicine idea. So in that work, we were able to deliver those recommendations on a weekly basis. I'm bringing this one up because then we were able to get back from the department the number of shots that were administered at each of these sites. So we could actually do that validation in the real world, which is quite rare. And we could see that the sites that were closer to the places that we had recommended within some radius, they were administering more shots. So we could do that validation almost in real time based on that data. In other work, which I presented briefly, we also gave them a reopening dashboard. So that was based on this mobility network model that we built of COVID spread and how to reopen. We also developed new use cases there, had meetings with them. We made new visualizations and everything. There, it was harder to get the exact validation because, it's just a much more political and complicated issue. So I have a lot of thoughts there on where it is easier and harder to get that feedback loop. But I think when you do this kind of research, it's really important to think about that end user of what is most useful to them.
And you're able to kind of engineer the data pipelines and your algorithms to render the updated predictions, et cetera.
Totally. Yeah. So that was a big part that I didn't mention, which was we originally had this model that was published in a scientific journal, but then in actually deploying it, we had to come up with a computational infrastructure that allowed us to run inference in a fast enough way that we could provide model predictions in real time. And this is for every other, lots of different counties and then thousands of potential reopening plans, because basically what the decision makers could do is they could decide on what level of mobility to have for 5 different types of POIs. Essential, and then retail, and then non-essential, I think grocery stores, and there's a list of 5. It explodes exponentially as you allow for different levels at each one. And so how do you do that quickly?
Great. Ida, if I would ask you to respond to Ziad's concerns about delivering information to clinicians. And how challenging that is in a BPA that no clinician wants to see, or in the corner of the screen where no clinician is ever going to look. How do you propose that we deliver insights from wearables, for example, that might be computed via Jupiter Health stuff? How do we deliver those insights to clinicians in a way that they actually want to see them and use them?
I think it was Ahmed who said that's an empirical question. And I think it is empirical. I think that there are the standard approaches, which would be the BPA. And for those of you who don't know, it is a red box that shows up that says best practice alert. And most of us just click dismiss, go away. There's the in basket. You guys all know what your in basket looks like. I don't think that works terribly well. What else? I mean, it could be, the little yellow sticky. Everybody uses cognitively, we use that screen space differently. There is a thing called a Smart on Fire window. Some of you know that, where you can open up a tab, basically sort of turn your electronic health record inside out and make a little window and paint something inside it. I think that has a lot of potential that can either be pushed to the clinician, or more likely the clinician can click on a tab. We click on a lot of tabs, and it can open up a space that then can have cognitive support layered in it. I think it's empirical where that's going to work. It's very complicated, or maybe it is talking to us, or, there are multiple ways. I actually want to flip that question around and talk about how we deliver some of these insights to people. And by people, I'm not talking about patients, but just all of us, right? And the point I want to make there is that we tend to think of patient data, and perhaps Sandhya can opine on this as well, that patients are somehow data sources, that they need to wear a sensor so that we can get data, so we can get insight, and they're just sort of passive data, but then they get bored of like charging their sensor or reporting their patient reported outcome. And one of the insights that I've gotten from my early work is that patients need to get value from the data and the effort that they put in. And so we need to think about what are the insights they want that answer their questions, and then how do we give this information back to them in a way that there's a value loop. And that is really the primary value loop, is what value they get out of the data that they're collecting about themselves. And then secondarily, that data can also help us in clinical. So it's kind of inverting, who gets the value first, because we need to recognize the effort that it takes to put on a sensor, I can imagine.
I can say I do a lot of my own clinical studies, meaning that we develop these prototypes and we put them on patients in the lab. And a lot of them have a lot of questions about what's the point of this and what have we seen? And so a lot of the stuff I showed, I actually have shown the people who come in to do the study, and they're very intrigued by the fact that, for example, they think they have a digestive problem, but it actually might be latently affecting their circadian regulation. And maybe that means they now start paying attention to their sleep and, the sleep quality, right? But they're very invested once it feels like it's something that's like, oh, this is very interesting to something that I can actually perceive. I completely agree, because I think one of the biggest, especially when it comes to wearables, one of the biggest challenges is compliance drop off. Mm-hmm. So the more that you require the person to maintain their device, they have to charge it, they have to whatever, over time, there's a drop off in compliance. Or you ask them to fill out more surveys or, more patient reported outcomes. Over time, there is kind of a drop off in how often they do it or how much effort they're putting into every question they're answering, right? And that is an ongoing challenge for sure.
Along those lines, looking at the pictures in your talk and seeing those things, lots of sticky stuff on there. I have some experience with this. I do some work with wearables and stick-on sensors for blood pressure monitoring, and they're very uncomfortable to wear. And so, how are you thinking about usability over time? And adherence and such, and what kind of use cases will allow you are good for devices that people are just they're not going to wear for a long time? And what are there use cases for devices where people really will probably use them for years?
Yeah. So when it comes to wearables, I often make a distinction between consumer grade wearables, or things that are meant for consumers or targeted at the general consumer, and clinical grade wearables, where their use case and what they're targeted for is different. So consumer grade wearables are, Fitbits, Apple Watches, your phones. It's targeted at anyone. You can go purchase them off the shelf. You don't need a clinical indication in order to get one. You don't need a doctor to write you a prescription, nothing like that. And, you could just be a generally health conscious person and want to wear them. And they're designed for different objective functions. They're designed to promote more comfort, to be convenient. Versus, there's a different set of wearable sensors that are specifically meant for a different use case, where a doctor is, perhaps it's only invoked when a doctor thinks that you have a specific reason that you need to be monitored at perhaps a higher kind of acuity or higher intensity. Usually the patients in those situations are willing to tolerate a slightly higher level of inconvenience. You're probably not wearing the wearable for months on end. It's probably a very defined window of maybe a few days, a week, 2 weeks. So you're perhaps willing to tolerate more inconvenience for that short amount of time. But actually, even that, there's a lot of rich information that you can get from just enabling the data collection to happen outside of a clinical setting. Even if it's only for what I do a lot of 72-hour studies. So it seems it's only 3 days. People are and those are very prototype devices. I will say I am in no way trying to compete with, Apple in making devices, but they're very prototype devices, and the patients in the study perfectly well understand that. But and they're willing to put up with the inconvenience for a couple days to get a sense of what the information could provide. So I think there's two kind of different use cases that have to be distinguished, and there's different opportunities and pros and cons in each one.
And I think you both brought up delivering information back to patients from the devices that they're wearing. Have you had experience designing that information delivery and any surprises related to that? And how does that, do patients always like getting the information that you give them?
I was going to say it depends on the patient. I usually wait for the patient to ask me if they would like the information, as opposed to me bombarding them with information that they may or may not want to know. The first study that I did, that I showed in the operating room, I was consenting people on the morning of their surgery. So understandably, there are a lot of patients who are very anxious and nervous and just were not interested in conversation very much. So they were happy. I was like, hey, I'm going to put some sensors on you. You're going to be mostly under anesthesia and they're going to be off by the time you wake up. And they were like, sure, happy to sign on. And they weren't interested in asking or finding out more, and understandably so. And then there were patients who would be happy while they're sitting there alone in the pre-op area to talk to me for 25 minutes and understand more about my research. And either they were really into technology, or they're, and so there's kind of a gamut. And I leave it kind of up to the patient to indicate to me to what extent they want to be involved in understanding what the purpose of the research is, or what their results or what their data could to tell them.
Any comments on that?
Yes. Often when we do these kinds of studies, we have teams of geeks, and we tend to like graphs and really complicated graphs. And we try these and put them in front of patients. It just doesn't work. We've tried radiograph, and bar graphs are probably the best. Line graphs are number 2, but what they really want is just a statement. So you might have a line graph, but you have a statement. You are doing better. It's really the qualitative statement is what they really actually index on. We kind of went, well, do we just provide the graphical information because it's more information rich if you could get at it? Whereas the statement, has some bias in it and how you say it. But we really found that you had to do both. Most people like having both. We did an N of 1 study where we got results back to people. You randomize yourself to sleep versus worse sleep, and see how that impacted your mood. And there was the prior estimate of whether an intervention worked. It was a kind of statistically very complicated. I don't know if Ben Recht is here. We've been talking about N of 1 studies. And it was really interesting. The patients really just could not. I mean, we went through so many rounds of how to display the results of like an N of 1 study. And really at the end, they just wanted the statement. But actually, at the end, they just did whatever they thought was going to work. Regardless of the results, they just did whatever they thought was going to work. So tremendous amount of work needed. And actually, maybe as we've been talking about AI, I think somebody mentioned about, large language models, and how do we use that to get people to really get at the data a little bit more? Because I think we're not a numerate society, and so there are a lot of limitations about how people really understand data.
Serena, maybe you want to comment on, I was going to have too much time. So maybe quick comments on how generative AI might play into things, and maybe how you can start and how it might add value to what you do.
Yeah, actually the talk I've been giving lately, this was the abridged version because it was 10 minutes, but the talk I've been giving lately is inferring and simulating human behaviors. And so there's this whole second half, which is work that I've been doing a lot in the past year, of instead of only inferring these behaviors, can we actually generate these behaviors using generative AI? There's a lot of exciting things around using LLMs. For example, we have work on generating social networks with LLMs. So you treat them as individual agents and you have them interact and see if they can come up with an organic synthetic social network. I talked a lot about how do we infer the contact network from mobility data. What if in addition or instead of that, you generate that network instead, using LLMs to come up with the connections between people. This would be really useful for hypothetical sets of individuals, also to get at the individual level instead of at the CBG level, which was still what we were at. So I think simulations of human behavior, there's been a long history of agent-based modeling in public health. It's very hard for us to run large-scale randomized experiments for lockdowns, reopenings. And so instead, we turn to what we call scenario modeling, of modeling these hypotheticals over realistic versions of societies where either the community or even the individual is simulated as an agent. I think it's extremely natural to ask, how can we build the next generation of that with LLMs as those agents instead?
Great.
Yeah.
Ida?
I don't know, maybe there are questions from the audience.
Sure. Shall we open it up? Yes. Audience members, yeah.
We do find that sort of setting little experiments and maybe medication or maybe chronic. However, when it comes to patients facing part of the EHR, it's kind of reduced. Basically, all I can do is use the messaging facility to give back my results to the sort of verbally agreed upon little mini experiment. The experiment itself is just verbal. There's sort of after visit notes, but that may or may not contain the little experiment. So there just doesn't seem to be, even if we were to sort of pursue this route of doing individual experimentation with N=1, the patient-facing EHRs just really don't help here.
EHRs are, they're really a workflow tool. That's what it is. It manages our workflow. It manages our billing. It is in no way a cognitive support tool. It is in no way a tool that helps us generate rigorous evidence. It is a workflow transaction billing tool. And it works well for that because, UCSF is an $8 billion enterprise. And a lot of the work that you hear going on here, I think, has trouble fitting into, a workflow system. And that's why we hear so much about the integration issues. But bringing it to the patients, I think as someone else said it, maybe it was Ziad, just don't go through the EHR. Don't use my chart. Go directly to the patients. And so there's work there too, but that's very difficult also.
I have one question about behavior change. So all of you are learning things from wearable and or population data, but that needs to be tied to a change in behavior eventually. So how are you thinking about promoting and causing that behavior change based on the findings that we get out of the data?
I guess in my perspective, I think from what I do, I spend a lot of time speaking with clinicians and trying to figure out what information would actually change something about what they would do for a patient. So, I as a researcher can have a lot of interesting insights. So like I look at the data and I think XYZ is interesting, but at the end of the day, if it doesn't change anything about from the clinician's perspective, what they would do for that patient or what they would, think, like it's interesting, but it's, of less value than figuring out what are the actual sticking points decision wise that they're, that the clinician would say for this patient, what I would really like to know is whether or not, if they're a diabetic, are they going to go and develop gastroparesis or not? Like that was one, for example, that the gastroenterologists were really interested in, is figuring out what subpopulation of the diabetic patients was going to develop gastroparetic symptoms or versus not. And so that helped direct kind of the research insights that we were then looking for to try and say, okay, if that's what's actually going to be actionable, or like that's the information that's relevant or interesting to them, then let that help direct the analyses or the methods or whatever we're doing on our end. So I think of it as like I start from that sometimes.
Yeah, if I could just jump in there. I think it's a great question. I think a big part of this stuff around inferring behaviors from novel data sources is then you can try to intersect that with interventions. So I'll briefly mention natural experiments that we were able to look at during COVID. We had this really rich mobility data that shows how much people are going to places, but then we could also look at California had a county level pandemic policy that basically had counties in different levels of restrictiveness. And we could take the mobility data to say, are people taking advantage of these county level policies to actually go over borders? And we saw an increase in mobility from closed counties to open counties. And we were able to come up with a causal inference framework that actually allowed us to estimate these spillover effects. So if you can combine these behavioral data with interventions, either natural or experiments you run yourself, I think it's quite rich.
Okay, time's up. Thank you.